Good afternoon. Profile and determinants of macular ganglion cell inner plexiform layer thickness in South Indians. Ganglion cells, being the final output neurons of retina, are essential for maintaining vision, and thinning of this crucial layer is seen in many neurological diseases like multiple sclerosis, Alzheimer's, Parkinson's disease, and also in glaucoma. But there's a wide variability of normal thickness among these studies, and there are limited studies, especially in South India and Kerala. So the aim of the study was to find out the normative data and determinants of macular ganglion cell inner plexiform layer thickness in South Indian population, and the objectives were to find out the normative data of patients attending OP in a tertiary care and to find the association of various demographic as well as selected lifestyle and neurogenic risk factors with this thickness. This was a cross-sectional hospital-based study done in ophthalmology OP of a tertiary care center spanning over a period of 1.5 years, and the sample size calculated was 168. Those who were included were aged more than 18 years with best cortical visual acuity of 20/20 with refraction within plus or minus 5 diopters per year and plus or minus 2 diopter cylinder. And those who were excluded were systemic and neurological diseases that might affect the retinal architecture, ocular disorders like glaucoma or ongoing inflammations, previous intraocular surgeries or laser treatment, any factors affecting the OCT signal strength like media opacity or non-dilating pupil. After obtaining informed consent, demographic data was collected and systemic history including diabetes, hypertension, history of smoking, alcoholism, and digital screen time were recorded. Visual acuity and anterior segment was evaluated. IOP was measured using Goldman applanation tonometry. Fundus was visualized after dilating. OCT macula was taken by a spectral domain OCT, and using the ganglion cell analysis program, the distance between the inner border of GCL and outer border of IPL was measured. Coming to the result, of the 168 sample, 55% were female, and the median age of the sample was 47.5 years, and majority, 26% were less than 30 years. 40% were diabetic and 21% were hypertensive. 6% were smokers and 22% consumed alcohol, and majority had a screen time of the range of 2 to 5 hours. The mean GCL IPL thickness from this study was 79.49 plus or minus 6.373 microns, and the males had a slightly higher of 79.79. Females had 3.86 times odds of having GCL IPL thickness below 80. GCL IPL thickness found to be significantly decreasing with age, with patients above 47.5 years having 13.5 times odds of having GCL IPL thickness less than 80. And negative correlation was noted between GCL IPL thickness and age with a decrease of 0.151 micron per decade of life. Significant thickening was seen in diabetics and hypertensives, and diabetics had 2.72 times odds of having GCL IPL thickness less than 80. And negative correlation was noted between duration of diabetes and GCL thickness, but it was not statistically significant. This data where a 60-year-old female who is diabetic and hypertensive for 10 years has a severe thinning of GCL IPL thickness comparing with a 25-year-old male with no comorbidities. Significant difference in GCL IPL thickness was noted according to digital screen time, with thinning in patients with screen time more than 10 hours. Smoking and alcohol consumption also caused thinning, but it was not statistically significant. Discussion. Normative data obtained from our study was 79.49, and from the parent study of Mansa et al. It was 82.1, and Sundaram et al. In the Indian study was 84.04. Insignificant thinning was seen in diabetics, similar to other studies by Shoki et al. And Pekal et al. And hypertensives also had a significantly thin GCL IPL thickness, similar to Lee et al. And Nam et al. To conclude, average GCL IPL thickness from this study was 79.49 plus or minus 6.3 microns. Age, female sex, diabetes, hypertension, digital screen time were found to be the determinants. What's the clinical implication of this study is, this study provides a reliable reference normative data of the South Indian population, especially of Kerala. And in diabetes and hypertension, GCL IPL thinning preceded fundus and OCT signs of retinal microvasculopathy, which has great implications in retinopathy screening. And to our knowledge, this is the first study in which digital screen time has emerged as a possible modifiable determinant of retinal neurodegeneration. What is the scope? Association of GCL IPL thickness and digital screen time need to be studied further with proper history of the type of device being used, any blue filter was used, distance from the device, quality and make of the device should also be considered. These were my references, and thank you.